Good morning. I'm Doug Blizzard with Catapult. So glad to have you here today to talk about a topic which affects us all. It affects our companies, it affects our employees particularly, and that is healthcare. And we're going to talk today about some new models that have emerged out there, which actually can help you to improve healthcare for your company in terms of costs, for your employees in terms of care. So glad you're here today. We got a lot to talk about in our short time together. A few admin things as always. We are recording this. That will be shared later for those of you who have to drop off or who want to send this to one of your colleagues that needs to hear it. If you have a question, please use your little command bar over there. Mine's to the right of my screen here. Yours may be at the bottom. Wherever it is, just ask a question and we'll try our best to get to the question. If we are unable to get to the question today, then we will clearly follow up with you with an answer. So again, thank you for joining, and let's begin. So when you think about healthcare, we've all been to healthcare reform webinars. We've done a bunch of them here at Catapult. And you typically hear things like, costs are out of control, they're unaffordable, it's unattainable. You see a graph with, how the famous graph we've all seen 100 times of the cost of healthcare is the very top. It's out of control. It's higher than inflation. It's higher than wages, et cetera. We've all seen those. We've all seen the horror stories of prescription drugs out of control and all the rebates and shenanigans going on there and high prices. We've all heard that, or we've experienced it as a patient ourselves. We've heard the horror stories. There was recently an article here on the news here in Raleigh of a married couple with the same insurance plan, went to the same system, the same health system, different facilities though, and with a similar MRI, and the variance in cost was about $5,000. You're like, how can that be? So we've all heard stories like that, about the healthcare system. We've all experienced it as patients. We've had employees, we had family members experience it. So we all know about that. We have one of the best healthcare systems in the world as far as care, but then the outcomes aren't always there because of accessibility issues and cost and whatnot. So today we're here to really talk about a challenge to that system, an alternative to that system that exists out there, that exists all over the country. And maybe you have, maybe you've not heard about it. And it's really called I guess the umbrella term might be high performing health plan. That sounds more positive than disrupting healthcare. So let's go with high performing health plan for now. Because we've all heard the talk. We've heard the talk for decades. I've been in HR now for, I guess 30 plus years. I think 20 plus years sounds better, but 33 years now. And my entire career, we've been talking about healthcare reform during that time. We've heard about value-based care, things like that. We've heard about other initiatives, but yet many employers, many employees kind of remain trapped in what I would just call status quo, what they've got right now. And they change their plans every 2 or 3 or 4 years to another plan similar to it. Costs keep going up. Employees are forced in many cases to forego procedures. And what happens? I mean, it's like this vicious cycle that never ends. Meanwhile, the employees are suffering from that. And so, what can we do as employers? I mean, I talk to so many employers every week, and I get it. Employers are distracted right now, and we just got through COVID, or we hope we got through COVID. We're right in the middle of Great Resignation. The talent shortages, supply chain, all these things are happening. It's just like, I don't have time for healthcare right now. Believe me, I get it. I get it. Challenge is though, while that's happening, who's really paying the price here is our employees are paying the price. We all know employees, we all know family members, maybe you yourself, who literally are not getting procedures or tests or medications that they really need because of the cost. And we just kind of are sitting there with our hands tied. We don't have any other options. But we do have options now, and that's the point in today, to talk about many options that are out there now that can help you lower costs, but also provide better care. I hear from a lot of employers, hey, we're fine, we're in a captive, or we've already self-funded, or we're now level funded, as if that's the solution. That's part of the solution. But I was told, 15 years ago by a consultant that I really admire and trust. He told me, Doug, until someone figures out how to affect the cost of claims, you're not really going to reform healthcare. And I think that's the real difference with these new plans. they're going after the cost of claims, not just trying to finance it differently, which will help you some, but it doesn't address, the 70-75% of your cost is the actual claim. So that's our point today, is to talk to you about, to listen to experts, to learn about some of these different plans that are out there that actually address claims. All right, so our agenda for today, something's happening, there you go. Again, I'm going to go through a couple of things about some common myths we hear, and I'm going to turn it over to a legend now in the healthcare space, Dr. Eric Bricker, who's going to talk about kind of these models as compared to status quo plans. We're then going to dive deep into some examples of what it looks like, how it feels day to day when you're in a high performing plan compared to what you might be used to. We're going to have a great panel at the end. I mean, obviously, healthcare advisors, maybe you call them brokers, maybe you call them healthcare consultants, whatever you call them, they are clearly at the forefront of the healthcare system and helping employers navigate. So we're going to hear from two very good healthcare advisors, brokers, consultants, whatever you call them, about what their experience is now out there as they're seeing more and more employers start down this journey. So next slide, please. I'll start here. So I hear a lot of myths out there about, and I'll get to them in a second. But what you see of these plans like this is, to take this journey, it does require self-funding. I mean, for you to be, most of the larger employers in the country are self-funded, and their healthcare costs are rising at a very low rate compared to the average, and that's because they're self-funded. They're able to get outside of status quo. They're able to get more control and to layer in more things like direct contracting, direct primary care, active and aggressive claims management, navigation by nurses and pharmacists. They incentivize and engage employees. All these things typically aren't available, or if they are, they're limited if you're kind of still in the system. Next slide, please. All right, so what we tend to hear from employers about myths, we hear this a lot. We've done a lot of these programs over the last 2 years. As you know, full disclosure, Catapult is an owner of one of these plans. Our employees are in one of these plans and having great results so far. We hear, I talk to a lot of employers about these types of plans. I hear things like, well, we're not large enough to be self-funded, so we really can't do this. Well, Catapult, we've got 50 employees on our plan. You can be self-funded even down to as low as 26 employees in this state. It requires, I heard this from several CFOs, self-funding requires employers to pay every bill. There's no limit. It's just, you're just writing a check for every procedure. That's just not true. And we'll talk about that later today. I heard this at the last event we did. Well, this isn't really a plan at all. It's just some financing thing. No, these are real health plans. They sit right beside. You compare them to your typical your carrier plan or your level funded plan, or it's a real plan. I hear things like they're risky. Employees won't like it. There are some of these plans at the very outer edge, which are things called reference-based pricing. Those are very risky, but most of these plans are not. I mean, our experience has been it's actually been less risky and volatile than our prior experience. They're complex, we hear a lot, for employers, employees, that they don't have to be. I hear they penalize employees. We had a few of our members that, yeah, I've got employees with bad conditions or MS or things like that. So I've heard horror stories about how these plans, they do these things called lasers. They don't pay for them. Again, there lasers do exist, but there are plans that don't have lasers. We'll talk about those today. I hear I must leave my broker. No, any broker can sell these plans. I hear that these plans reduce provider choice. These are narrow networks. No, most of these plans are built on top of a PPO plan, and they actually exist alongside of an existing PPO plan, which means employees have ultimate choice. And then I finally hear things like these plans bring balance. I've heard horror stories where the employee goes to the hospital to get a procedure and they get the full bill. They get a $50,000 bill for the procedure. Again, that's these reference-based plans. We're not talking about those today. We're talking about high-performing plans that are going to feel like what people are used to, but they're going to be very different when it comes to the quality of care and the cost. So a lot of good things out there that are happening. I hope today you take away at least one nugget from this program today. If nothing else, just the reality that there are plans out there now that can help you provide better care, can help you save money as well, and aren't risky, aren't complicated, aren't complex, aren't disruptive in the sense of the employees have to go to narrow networks. And I hope you learned that today, and that propels you forward to at least take a look at these. Let's do a quick poll here, Abby, before I introduce Dr. Bricker here. You can pull our poll up here. All right, everyone, please, if you please select what are your top concerns when it comes to your health plan right now. I'm curious as what you're thinking right now. All right, how about the results right quick? Interesting. So the top response here was employees are paying too much. That is something that often doesn't get reported a lot in these programs and on the news, but it really affects people. And I worry about a lot how many employees are putting procedures off. We're paying too much, so cost is a big issue, especially drug cost is a big issue. Navigation, healthcare is too complex. I mean, if you've had to live through a family member or a relative, which I have recently in the last few years, you quickly realize you've got to have someone on your side trying to navigate this system by yourself, particularly if you're the one that is sick or infirmed, is just almost impossible. So, but definitely cost is a big issue. Okay, thank you for that. All right, is there a question I can answer before I move on? Let's see a question here.
There are no questions quite yet.
Yep. Okay. On question.
All right. Well, great. You've heard me talk enough. Let's bring on the expert again. Dr. Eric Bricker. I mean, if you never heard of ahealthcarez.com. Hey, Dr. Bricker, good to see you. Ahealthcarez.com is probably the best resource online for you to keep up with and learn about the healthcare system, new things that are happening. It comes in the form of a 3 to 5, sometimes 10-minute YouTube video every day, and you get to see this gentleman in front of a whiteboard, and he breaks it down. So I'm so excited to have Dr. Bricker here to talk to us today about just demystifying some of this for people. How about next slide, please? You can see Dr. Bricker, a long list of credentials here. What I like the best about Dr. Bricker, he actually was in the system. At various different parts of the system. You can see that his background there, internal medicine residency, hospital physician in Baylor, Plano, Texas, co-founder of Compass Professional Health Services. He's been at this from different angles. Again, how I know him is through ahealthcarez.com. It's just a wonderful trove of information that really helps me understand and can help you understand this system, how it really works, not how you might read about, but how it actually works. And so again, Dr. Bricker, please take it away. Looking forward to your talk today.
Well, listen, thank you so much, Doug, and to all the viewers and listeners for having me. This is my second time with Catapult. So I actually wore a Tar Heel blue tie last time I was on. So to be fair to the people of the great state of North Carolina, I'm wearing a Wolfpack red tie today. And if I get invited back, I'll just keep going through all the various schools. But I appreciate being able to be here. And as Doug said, so I'm an internist. I actually initially began as a healthcare finance consultant. Also practiced medicine at a community hospital outside of Dallas, Texas, where I'm located here. Founded a healthcare navigation company that grew to over 1.8 million members across 2,000 employers. Sold that business, actually then became the chief medical officer of a virtual primary care business, telemedicine business as well. I've recently left there, and I've continued to do these aHealthcareZ videos. So I literally have spent the last like 12, 13 years just talking to employers, broker consultants, CFOs, CEOs about their health plans. And it's very important. Doug brought up a great point when talked about claims cost, and all of you in that poll said that cost to the employees and your premium costs were the two largest problems, right? So obviously health insurance is expensive because health care is expensive. Now, health care being expensive is not this big amorphous topic. It actually has very discrete causes. Okay, so it's very important for us to understand the nature of those costs. And that's what I'm going to go through on this slide. So point number one, many of you are probably familiar with this. It's the 5-50 rule. Okay, so 5% of claimants are driving 50% of your healthcare costs, right? So it's your high cost claimants. Typically, those folks have in excess of $50,000 or $100,000 of total claims cost over the course of a year. And that's a combination of their medical claims and their pharmacy claims together. It's in your high cost claimants. It's also thought of as the 80-20 rule, right? Where 80% of your healthcare costs are in 20% of your health plan members. So it's not, you don't have to boil the ocean, okay? So it's not across all your folks. It's really concentrated in a small number. Now, on the flip side, where because, and the majority of that is in the medical, right? So for a typical health plan, they spend about 20 to 25% of their spend is on pharmacy, and about 75 to 80% is on the medical. And the vast majority of the spend on the medical side is from the hospital facility charges. So if we want to understand healthcare costs, we need to understand the healthcare costs for those hospital systems. And that's what point number two is. So point number two is, look, if you're on the hospital side, a hospital's revenue is split up in this fashion. So they get 40% of their revenue from commercial insurance, Blue Cross, United, Cigna, Aetna, which is essentially employer-sponsored insurance by all of you. They get 40% from Medicare, 10% from Medicaid, and about 10% for self-pay. Now, each hospital varies a little bit, but that's generally how the hospital breaks down. The important point here that you probably are also familiar with as well is that the hospital gets underpaid, has very low reimbursement from Medicare, Medicaid, and self-pay by the hospitals is referred to as no pay. They essentially don't get paid for that. And so point number three here is that hospitals use what's referred to as cross-subsidization, where they essentially overcharge Blue Cross, United, Cigna, Aetna, i.e. employer-sponsored health plans, to make up for the fact that they're underpaid by Medicare, Medicaid, and self-pay. And so many of you probably familiar with the Pew and Rand studies that show that even after a Blue Cross, United, Cigna, Aetna discount, that the allowed amount on a commercial plan is still on average upwards of 250 to 290% of what Medicare reimbursement is. So even if you have like the best commercial discounts, it's still 2.5 times more than Medicare. So it's that cross-subsidization by the hospital systems that makes healthcare for employers so expensive. Now, part of what drives that on the hospital side is that they themselves actually do not do something called cost accounting, which is where by test or procedure, they actually don't know what it costs them to deliver it. In other words, for like a gallbladder resection, a gallbladder removal, which is called a cholecystectomy, they couldn't tell you specifically how much it cost them. Or for like one MRI scan, they couldn't tell you how much that cost them. So most businesses do cost accounting. So if you ran, most restaurants in America, they said, okay, well, how much does it cost to literally make the hamburger? And there's different inputs in the hamburger, right? You got the hamburger, you got the bun, you got the lettuce, et cetera, et cetera. By the time you put all that inputs in, they could tell you, okay, it costs us $5 to actually make that hamburger, and we charge $10 for it, or whatever it is, right? So hospitals can't do that, or I should say they don't do that. And it's because hospitals are so labor intensive. So literally you would have to do time studies on the amount of time the nurses and the surgeons and the various people spent on various types of care in order to do that. So what the hospital does is they just say, okay, well, look, we're kind of, we just look at our budget over the total year, and we're kind of getting underpaid by Medicare, so we're just going to keep ratcheting it up on the employer side. And so that's why you get these completely irrational payments for services, where an MRI would cost $3,000, or a surgery would cost $15,000, or you get like a little ER visit with 2 stitches and they charge $12,000 for like 2 stitches in the ER. It does not cost the hospital $12,000 to put in 2 stitches in the ER. So that's why there's this complete disconnect, because they don't know. Now, there's a handful of hospitals that do cost accounting. Interestingly, like the University of Utah down there is one of the examples, is hospitals that actually run their own health insurance companies. They actually sell their own health insurance, like the University of Utah or the University of Pittsburgh Medical Center or Intermountain. They know, because they have to charge premium and do underwriting. So of course they know their costs. So what I'm going to go into next is, obviously, you as an employer, you can't change this about hospitals. We're just going to accept those as a given and say, okay, well, what's within our power specifically about the high cost claimants that we as employers can affect? Next slide, please. So here you have a pyramid. And at the base of the pyramid, in terms of a high performance health plan, this is how things are misaligned today. So primary care in America largely doesn't work. One, because people don't go, and they don't go because it's incredibly inconvenient. And a lot of times they just don't want to pay the money. And then 2, when they do go, the doctor doesn't spend, the average primary care visit is anywhere from 8 to 13 minutes if you're lucky. That's just not enough time. So it's really a matter of people just not going in time. And if you, and I, believe me, I've looked at claims for employers, for hundreds of employers, and typically only about a third to maybe, if you're lucky, a half of the employees have actually seen a primary care physician in the prior 2 years. So just know that going in, like if you didn't really have the data on your plan, that just know that actually a lot of your people just have not seen a primary care physician in the prior 2 years. And so what happens is that a lot of people then use specialist care. And the problem on the specialist care side is that specialist care follows a bell-shaped curve in terms of ability, right? You're probably familiar with Lake Wobegon, right? Where every single child is above average, right? Well, that is obviously ludicrous, right? Well, that's also ludicrous when it comes to all physicians. Not all physicians are at the top end of the bell curve. And so the point is that when you have especially high cost claimants and complex members, like you need them going to the most competent specialists. And not, frankly, there's ones in the middle and there's ones at the bottom. There are incompetent physicians in America. Of course there are, because they follow a bell-shaped curve. And then with the pharmacy, you're going to hear fantastic conversations around pharmacy later, but really the entire PBM model is aligned to prescribe more prescriptions and prescribe more expensive prescriptions. And if you listen to the investor calls for all the major carriers which own PBMs, all the Wall Street analysts ask the carriers about script count, and script count, because they know that that's a metric for revenue for the PBM. So the PBM is actually incentivized for your employees to be on more medications and more expensive medications. And you as an employer, you want them being on less expensive medications. And there's many things that you can do to get people off medications. And then finally, a lot of this has to be driven with data, right? So that's the status quo for today. And then briefly here at the end, I'll tell you what the new model looks like. And this is, again, this is all focused on high cost claimants. Next slide, please. So in order to address your high cost claimants, you actually need to start with primary care. And I will tell you that this is not some sort of like Eric Bricker pie in the sky idea. There are literally small self-funded employers in America that are doing this today. And literally one of them, Saragraph, which makes dashboards in Wisconsin, has kept their healthcare costs flat for 9 years. And I'm sure all of you wish you were paying the same for healthcare today that you were 9 years ago. And so they implemented many of these strategies to actually make this happen. So one, they offered primary care literally outside of the system, literally for free. And they did that in a very straightforward way, either with an on-site clinic or a near-site clinic or virtual primary care that was paid for not through claims, but they essentially hired a company to have an on-site clinic or a near-site clinic, or they hired a virtual primary care company to do this, or direct primary care. So there's many direct primary care doctors in North Carolina, South Carolina, and Virginia as well. So it's very doable. And through those relationships, they would then say, okay, because there's no claims, we're offering it to the employees for free. So we said the two problems was that people don't go and the doctor doesn't spend enough time. So when you make it free and virtual for folks, you dramatically increase, you reduce the barriers, and you dramatically increase participation in primary care to identify and prevent cardiovascular disease, to identify and treat musculoskeletal disease before it requires joint replacements, and to perform the appropriate number of screenings for cancer so you can't catch the cancer earlier. Because those are the three diagnostic categories that drive your high-cost claimants: cardiovascular, musculoskeletal, and cancer. And you can't address those after they've already had a catastrophe. You have to address those in advance through primary care. So primary care is actually the foundation of your high-cost claimant strategy. And then two, you want them off of claims, because fee-for-service incentivizes the doctor to see as many patients as possible to maximize their reimbursement. That's why they only get 8-minute visits, because the doctor just wants to churn through patients so they can bill. You want to pay them a fixed amount so that if they need to spend a half hour, 45 minutes with a patient, that they can do that and they don't feel rushed. Because if you can spend 45 minutes with a patient with congestive heart failure, COPD, diabetes, hypertension, and you can, listen, if I have a complicated patient like that, I cannot adequately provide primary care for them in 8 minutes. I need more time. Now, by the way, that 45-minute visit can keep them out of the hospital for a $15,000 stay, but you got to give them time by getting them off the fee-for-service hamster wheel. Then with specialist care, there are programs out there that actually connect plan design to where you can actually steer patients to the highest quality physicians and have much lower out-of-pocket costs for those high quality physicians than for the low quality physicians. Because obviously, people understand the idea of value. And so if you have higher value specialists who frankly are better, then you want to make that a better value for your employees and steer them to that. So primary care is a great place to start, but then you have to have your plan design aligned such that when the primary care physician sends them to the high quality specialist, it's actually financially beneficial to the employee as well. But you said that employee out-of-pocket cost was a major concern. This is a great way to align your plan around that. Pharmacy care, if you go self-funded, it allows you to then do a carve-out transparent PBM that is not aligned to prescribe more prescriptions and more expensive prescriptions for your employees. So that's a huge benefit of being self-funded, is that allows you to then do a carve-out PBM, and then it gives you greater access to your data so that you can actually see the detailed results and take action on that data. So with that, I will pause or end, and Doug, let me pass the floor back to you.
Wow, now you see why I watch him every day. So in a couple of minutes, I mean, Dr. Bricker, I mean, you know, what you're saying makes perfect sense. Why do you think it still eludes a lot of employers?
Well, it's interesting. It generally needs to be driven by the executive team. So obviously HR is involved in that, but it's also CFO and CEO driven. And you know, CFOs and CEOs, they got gobs and gobs of priorities, right? They're constantly fighting fires. And so what's interesting is that in the tight labor market that we've seen over the past couple of years, interestingly, the primary driver has been around making the benefits an attraction and retention tool. And so actually especially the CEO has been interested in offering free primary care as a way to keep and get employees. I will tell you, an unnamed large fried chicken chain that's based out of North Carolina did that exactly. They were having a hard time getting people to work at their restaurant. And they could say, look, you come work at our restaurant, you get free primary care. And they did it virtually because obviously these people were working hourly. So if they had to take time off of work to go to the doctor, they wouldn't get paid. So guess what they would do? They wouldn't go, right? And so they said, well, we have to give them a free virtual service to attract and retain people. That was a huge problem for them. And so the point is that it's really important, and all you HR people know this, is to partner with the executive suite and be like, look, what are the strategic pain points for the organization? It might not be claims cost. It might be attraction and retention. It might be about the out-of-pocket cost for the employees themselves. And so it's framing your plan strategy in a way that's addressing the acute business challenge of the CEO and the CFO, like at that moment, right? Because being a CEO is all about fighting fires, right? If you ever talk to a CEO, like every day they are fighting fires. And so if you can come to them with solutions to help fight a particular fire, then they're going to be highly interested.
That's good. I like that. Can that live beside a traditional plan? Could you put like one toe in this and just start DPC?
Oh, absolutely. I mean, all these things are highly modular. And so it's really just a matter of taking the initiative. Now, understandably so, many HR people are concerned about taking the initiative and then having the program fail, right? So very HR leaders are risk averse. I totally get that. And so that's where it's really a matter of up managing the executive suite and really getting buy-in from them. And I have seen wonderful HR leaders who really feel a sense of mission. Honestly, they do this because they see their employees struggling with like cancer diagnoses or family members that have had very serious things. And it's so hard on the people. It's so hard on the people. And so they really feel that they as HR people are advocating for their employees by up managing the executive suite, because no one is tuned in more to the employees' lives than HR. And so if you can advocate for the employees in a way that gets the executive team's attention, then like I've seen it work when even it doesn't work. In other words, if there's hiccups because you've done the work to get the buy-in from the executive team in advance, like to a certain extent you manage their expectations and you're able to work through those hiccups.
That's good. That's good. Wow. I could go on to do this for hours, but I think we've got a time window here. So again, if you want to hear more, Dr. Bricker, take AZ and put healthcare in between it, ahealthcarez.com, and you can hear on any topic. We had a few questions. What's a BUCA? BUCA stands for Blue Cross United, Cigna, Aetna, Humana. What's a PBM? That's the Pharmacy Benefit Manager. You're going to learn more about that in our next session. So Dr. Bricker, thank you so much again for your time.
Thank you for having me. Appreciate it.
Yeah. Okay, wow. Very informative there. Hope you learned a little nugget there in terms of how this system works and if there are options out there. We're gonna jump now to kind of diving into what does kind of day in the life look like when you're on one of these plans. So if my next speakers can join me here, we'll get going on our next session here. We've got three wonderful speakers here. Patrick Long, who's the CEO of Hero Health Plans, which is a local high-performing health plan. Faith Barron, RN, who's a nurse navigator. She actually is the nurse navigator on Catapult's health plan. So I know Faith, as do many of our employees, know Faith very well. And then Vinay Patel, founder and pharmacist at Mako RX here in North Carolina. Again, many of our employees here know Vinay well. And so I'm going to turn over to you guys to start talking about how the experience feels different in a high-performing health plan.
Yeah, thanks so much, Doug, and thanks to Dr. Bricker, an inspiration. I've got my own whiteboard here. I see Vinay has one, Faith has one probably close by. We really appreciate all that he's done and continues to do to move the needle forward for employers to move to value. As we say at Hero, better outcomes and higher incomes are the twin goals of everything we do, both for the plan and the working people. So Abigail, if you can go to the next slide, we'll get started here. What we wanted to talk about in our session today with Nurse Faith and Vinay are just focus on the 3 C's, we like to say. If you're an executive with an employer in HR or financial or a CEO, if you're an advisor, we have a lot of broker advisors on this webinar today. We want you to just focus on these 3 C's for our little session here. Does your plan, your status quo plan, deliver these? If you're responsible for this, you have to look yourself in the mirror and ask, is my plan delivering better care for our employees and their spouses and dependents? Is it delivering lower costs, not just for the company? Dr. Bricker talked about the rising deductibles and rising premiums and things like that, but also the employees. Are you, everyone's impacted by the Great Resignation and the struggle, the war for talent. Are you putting forth a plan that's increasing retention and recruiting and reputation with lower cost? And finally, can you get more control? The BUCAs are determined and driven by Wall Street money to take control and keep it from you. They hide your data. They sell your data. They don't give it to you. That's abhorrent to us, and really gets me upset sometimes that they have their data. And when we get reports back from some companies, let's say they're near Durham, they actually go through and scrub valuable data out of the reports before they give them to us. It's just amazing to me. So the hubris, but focus on the 3 C's, the better care, lower cost, and more control. And we'll talk about those a little bit right now. If you could go to the next slide, please. So Faith, I wanted to start with you and talk about better care. And you're the nurse navigator for many plans, including Catapult's own plan, with about 100, I think about 50, 55 employees, about 100 people on the plan. And you work very closely. Can you tell us a little bit about how do you provide better care for employees? And I put the little images down there of what's on your kind of desktop there.
Sure. So thanks, Patrick. So one way that I provide better care for employees is I use predictive analytics. I use the data that comes from the claims to target and meet and greet and develop a relationship with employees that have high claims or have serious diagnosis that perhaps need help for navigating the healthcare world for those chronic disease. As Dr. Bricker said, those that bell curve exists for physicians and they're not created equal. So we want to make sure that people with chronic disease are getting to the top of that curve and getting to the best. And I have analytics and data that I can pull that we pay for that's ways to make sure that the doctors you are going to or my patients are going to are top scoring physicians in top scoring centers with low infection rates, high quality results. Do that. We use lots of centers of excellence, make sure that they're clean facilities, and infection counts are down and complication rates are down. That's what we do. And developing a relationship with the employee is very big, so they call before they have a need, and I work with them through that chronic disease or through that surgery from the beginning to I have knee pain to I come out with a great result and a good knee.
That's great, and it's the data is all available. It's so interesting to me when I met you, Faith, is that we talked about the provider platform in the middle there. That, like Dr. Bricker said, of course, all PPOs or the BUCAs treat all doctors equally, and I think the thing that we really noticed is, of course, that's not true. And what I like to remind people, and I'll tell everyone on this call, what happens on July 1st, I used to tell people. And they're like, I don't know, I get ready for the holiday. And it's no, all the new surgeons are released from residency to begin cutting people, doing their surgeries, and doctors everywhere at Duke and UNC and Novant and Atrium and everywhere else on July 1st. So, does surgeon quality matter? It absolutely does. Does it matter more on July 1st? Yes, it probably does. So we take that provider data very seriously. And on your platform, I know you have everyone ranked by like volume and outcomes, and we have complexity. You also mentioned facilities. It's not just the surgeon or the doctor, it's where they work. There's a major hospital here in North Carolina that has a C rating for infectious diseases. I wouldn't send my mother there, but the PPOs are sending your employees there every day. I mean, the folks that are listening. So it's really important to utilize the data that we have. But Vinay, I wanted to bring you into the conversation too, because you also have access to all of this. And did you want to, speak to some of the data that you see as a pharmacist? And
Yeah, absolutely. So I wanted to, Doug brought up a great point. He said that we've had a few questions about what a PBM is, how it works. I'll take just a minute to explain that. So PBM stands for Pharmacy Benefit Manager. If you have a Blue Cross Blue Shield plan in the right hand or some corner of the insurance card, you'll see Prime Therapeutics. That's the Pharmacy Benefit Manager. What they do is they contract with pharmacies and they contract with employers to help manage everything that happens inside of a pharmacy. If your employees are going to a pharmacy, they're using a PBM to get one of their drugs as part of the plan. So the plan and the PBM sets the formulary, determines the charges they have for drugs that your employees take, how much they pay in copays, so on and so forth. And we can answer some more questions about that as they come up later on. But let me jump into what Patrick had mentioned now that we've sort of laid the groundwork, which is care on the pharmacy side. And so, one of the things that we're really excited about when it comes to a plan that's self-funded and Hero Health is it really takes a team of folks to manage a plan really well. No one person can do it alone. As the plan Hero Health, they have consultants that they work with. There's Stop Loss Insurance, there's Nurse Faith, there's myself on the pharmacy side. We all work together with everyone at the employer group, all the executives and all the employees. And to that effect, we have a great care story that came up just a couple weeks ago. We had one of our employer groups, the HR representative, was helping a new employee pick their health insurance plan, whether a high deductible plan or a copay plan. And the employee had some questions about their medication. The HR representative immediately said, reach out to Vinay and his team at MakeRx, and they'll help you figure out what would be best for you to choose as in regards to prescription costs. The member reached out to our team and talked about, the couple of medicines they were taking for themselves and their family members. Not only were we able to educate them about the medicines that they take, how they work, what alternatives are available, because for some crazy reason, they were taking a brand name, high cost medication when there were multiple other generic options available. And they said, no one took the time to ever explain this to me. No one told me how my child's medicine or my wife's medicine works and what the alternatives are. Yes, there's great pharmacists that work at these chain stores, but they just didn't have the time to explain that to me. My doctor didn't have time. And so this was extremely educational for the member and their family members taking all these medicines. And then we told them what the cost would be on our plan. We know upfront what the costs are, and we're completely transparent about what those costs would be at either a chain store or at a local store where we have cost plus pricing. And so the member was able to make an informed decision upfront before they were able to choose their health plan. And the second thing that they told us was, wait a minute, you're telling me that I don't have to go use a chain store? We can use the local pharmacy that we've been using and getting excellent care at with our local pharmacists, knowing everything about our family members. We've been seeing them for the longest time. That is so grateful. We've been, they've heard stories of our previous health plan when we used to go in and the pharmacist would tell us how, they weren't able to make enough money to even cover the cost of the medicines. And they said they're really excited about working with MakeRx and that we're working with local pharmacies, and the type of and the quality of care that they'll get by continuing to work with the local pharmacy and now being part of the ecosystem was really impactful and speaks to the care on both sides.
I'm gonna butt in, sorry. There's a question asked, and this is an important question, because I think it gets to one of the myths I talked about earlier. One of the myths is this isn't really a plan. The question is, so in your story you're talking about right now, how does the employee even get an RX? Talk about that.
How do they get a prescription?
Again, I think some of the myths are around, are there even doctors involved? How do they even get a prescription filled? That kind of thing.
So we're above where the care is provided. So if you think about us, your employees can continue to use the doctors that they continue to see today, and they can go access almost all the doctors that they have access to today in their plan when they switch over to Hero Health. And when they see one of those doctors, that doctor will write a prescription for them, and they'll ask the patient, where do you want to go get your medicine filled? Patient will tell them a pharmacy. They'll walk into that pharmacy. They'll show them their new insurance card, and on that card, they'll say MakeRx on there. Pharmacy knows what to do with that, and it gets processed through our plan. And voila, the patient gets their medication, depending on the cost that were set for the plan. And then Nurse Faith and I reach out to them and say, hey, did you know you could save money by using a local pharmacy, or whatever the case is, or there's these alternatives, or let me educate you about the medicines that you're taking and help you save and access better quality care. And so nothing changes about the plan today. Patrick?
Yeah, no, that's great. So to sum up the care slide, we've got to move along, is it's data driven, but the relationships are so much more important than telling your members to go to Cigna.com or call the Blue Cross hotline, where I was waiting for days, I think, at various points in my life. We have real humans right here, super experienced, accredited, that reach out and help your humans navigate the complex system. So it's data driven, but it's really the magic happens with personal touch. If you go to the next slide, we'll keep it moving. So another part about this is the lower cost. So we covered the better care. What's critical though is budgets are constrained, inflation is rampant. Healthcare, as Dr. Bricker said, is super complex because of all the accounting issues at hospitals and others. What we did for lower costs are two things. One is we had to save the plan a lot of money in order to incentivize the people to help their out-of-pocket costs. Because when we wake up in the morning, we serve three constituents. First are working people, number one. Second are employer plans. And third are top providers. And what we do is keep that circle very tight, so it's a virtuous circle. Part of it is lower cost. The shocking thing, and Doug, you need to add this to your myth list, is that better care costs less. Very few people understand that. But what we're looking at here is just one example of 1,000 examples because it's familiar. So a knee or a hip replacement at a Buca, if you go to Blue, United, Cigna, Aetna, and you go to Duke or UNC or Novant or Atrium or wherever, it's going to cost north of $48,000 when you add up all the bills. We saw one for Mission Health that was over $100,000 a couple of weeks ago. With Hero, it's $24,000 with the top doctors in the area, some of the best top in the state, at a better facility. So how did that happen? That happened because the top doctors actually like working directly. They hate insurance more than you do, believe it or not. If you talk to any surgeon like we do all day, they can't stand insurance. They want to see patients. They want to get paid not from your employees. We charge zero. If your employee calls Faith and says, I unfortunately need a knee replacement surgery, she finds the best doctors in the country that are here nearby, schedules you, works with that, and it's $24,000. So it costs the members zero. Why would the top doctor do that? They hate insurance so much, they'd rather get paid $24,000 directly than chase after $5,000 or $6,000 from your employees for 3-year layaway plans. And then they have to call Blue Cross or Cigna all day and try to get repaid. So they gladly accept our money. You get a top ranked doctor. I think we only work with fellowship surgeons right now, the highest, the cleanest facilities, and it's one bill. Your patient pays zero. And so
Patrick, a quick question for you.
By all that money, you're able to incentivize your employees and get them to choose that for zero. So Faith, can you walk us through some of the examples there? Or Doug, you might have a question.
Yeah, the question is interesting, and we hear this a lot. It's important to talk about cost. The participants today all said cost was a big driver, but a lot of times when you put an example like this, people think what this is all about is just trying to find cheap providers. They'll do things cheap. Faith, talk a little bit about how you steer employees when they call you or when you call them.
Sure. So as I mentioned earlier, we've paid for subscriptions to companies that use high-tech equipment and programs and things to figure out doctor scores. So I only send people to physicians in the top above 85th percentile in scores out of 100. So if they're below that, I don't direct anybody there. I don't shepherd anybody there. I don't want to send someone to someone who's got bad scores for knee replacement and then they get an infection and have a big impact on their life as well as a huge bill for the employer. That's how it works. People usually call me ahead of time and say, hey, I'm having knee pain. And that from that moment on, we develop a close relationship. I help them find a provider for the surgeon, an MRI, the actual procedure for physical therapy, and then just check on them throughout that process. As they walk through that, I'm there for them via text or email or any way that I can help, but then they're seeing top quality providers, so their outcome is better. And as Patrick said, they just call me, if someone I do not ever, it's within 24 hours, I have answers for people and I get back to people. You're not ever on hold with me for days. I have one of those BUCA plans through my husband's employer, and man, I tell you, I do feel like I'm on hold for days. That doesn't happen with Vinay or I. We answer questions quickly and have that relationship with our members.
Yeah, thanks, Vinay. Thanks, Faith. Can you go to the next slide, please? So, moving along here, so we talked about the high quality, we talked about data-driven decisions, but delivered by humans, by friendly nurse navigator and friendly pharmacist, as we like to say. And then the lower costs come from direct contract. But the other thing is control. Like Faith and Vinay, you know that when we do meetings and renewals, what people really are, will say, even before we saved them 500,000 or whatever it was on the plan, they'll say they really like the fact that we're getting control and we're using the data positively. So we're able to be proactive and say, hey, we saved a lot of money. Now what's next? That's all. We hear that a lot, right? Let's do a smoking cessation program. Let's do rewards for weight loss. Let's do something to address our chronic conditions better, so we prevent things from hitting the plan 3 years down the road, 2 years down the road. That's what gets us excited, right? Once you get all the data, we don't hide it or sell it like Blue, United, Cigna, Aetna. We share it, and that seems fundamental to me. Can you talk a little bit about, your experience, maybe Vinay, on the information you have and the control you give?
Yeah, so one of the things that's most impactful, like Patrick said, to executives at the employers that we work with is every month we're sharing data back on not only the top medications, but the important data that they want to know. We can drill down to any level of detail that anyone wants to see, but at the high level, we're sharing important data around the 3 buckets that we have for medications. What's your specialty cost, and what are we doing about it? How are we helping to manage that proactively as a fiduciary on the plan? What are your brand costs? What are we doing to help address and make sure to educate those members on medicines like diabetes and cholesterol and blood pressure, that cardiovascular concern that said is a top cost driver, Dr. Bricker mentioned? And how are we doing to steer and drive patients to better quality access to medications that are more cost effective? And then on the generic side, our cost plus model is showing exactly what the cost of these drugs are, whether it be a penny or whether it be 10 or 15 or 20 or $100. We're showing you exactly what the cost is for the drug plus the amount that you're paying as a service the pharmacy is providing to your members. And that kind of access and data and then steering it. We had an employer group just at the last renewal said, I want to increase the copays that patients pay when they go into CVS, Walgreens, and Walmart, so that they can drive more traffic to local pharmacies, because we see the quality of care and the cost savings we're getting when we drive to local. And that's part of the control that plans have as pharmacy. Yeah. You don't get today, or a plan that said, I want to help adjust the formulary so we include drugs that are lifestyle, cosmetic medications, because that's what we want to do for our employees. Great. You can change your formulary however you see fit. We're just here to provide guidance, but you have the control.
That's great. If you go to the next slide, please. So we'll wrap up here with, our portion, and the net, and this maybe is we should have led with this. This is the exciting part, right? Is all the savings that come from the steerage to higher quality, lower cost, direct contracts, data, all of that, it enables and empowers this, that we don't penalize your workers with high deductible health plans. You don't need to be, this is what one of our CFOs told us, we don't need to be ashamed or embarrassed about our $4,000 deductible anymore, because we're offering all these 20 benefits at zero out of pocket for all of our employees and their families. And so instead of trying to find a way to knock premiums back down and keep your budget, which is about impossible, what we do is say, let's deliver the care for zero if you call your nurse first. you get access to all of these things from, zero out-of-pocket MRIs. Doug talked about one that's $5,000 here locally on the news the other night. Our MRIs are $650 at the same facility. So you can pay $5,000 with your Blue Cross plan, or you can pay $650 and give it to your employees for zero with us. And it's amazing. It's stunning that some people are like, yeah, but they've got a great logo, I'll go with them. You're just penalizing yourself and your people. All these other things are available for zero out of pocket, from second opinions at Mayo Clinic to, as Vinay talked about, generic drugs. Over 300 generics are available now at Harris Teeters, all the Harris Teeters in the Carolinas, Kroger's nationally, and like 12 or 13,000 other locally owned pharmacies are zero out of pocket for generics. Because Vinay's team has got a great deal with them. It saves the plan money. Well, pass some of that savings down to your working people. You would believe this has a huge impact on recruiting and retention and reputation. And so these are just some of the things that our team has put together, and we continue to look for new ways. We're hearing Faith is talking to all of your employees, getting feedback and saying, here's something else we need to add, diabetic equipment or test strips or whatever, mail to the home. We're continually adding new things to the zero out-of-pocket program, the power of zero. So when you go to the next slide and let Doug, we'll hand it back over to Doug. But thank you so much, Faith, for all you do. And thank you, Vinay, too. We can maybe hang on for a minute while Doug does his case study.
Yeah, go back to that slide. Yeah, just in case you're curious, and we're getting questions. We have time at the end for questions. So I've answered a few of them. A few of them I couldn't answer, but we'll get those at the end. I want to give enough time for David and Suzanne, who are on the front lines of this. I can't wait to hear their session. This is a case. This is ours. This is Catapult. This is our experience after 1 year on one of these high-performing health plans. Again, 23% savings in 1 year. Trend low. Our employees are, I mean, as Patrick said, we're one of the most active groups in terms of our employees calling Nurse Faith, calling Vinay's team. Again, I'm not sure how we get to 74%, but it's a high engagement. We've had issues, we've had calls, we've had claims, but yet we've had a very good experience, such that we're not raising our rate. We're going to be like that. What was that Sarah graph? We're not raising our rates next year, which is the first time. Oh my gosh, I can't recall the last time we didn't raise health insurance premiums for our employees. So we even talked about lowering them. We're not going to do that the first year to be smart about it financially and to see what happens next year. But again, great experience for us with our employees. So it's been a very good year for us. It's not been complex. It's not been risky. CFO's happy. HR person's happy. So it's been a good year for us. So all right, I want to now dive. Thank you so much, Vinay, Faith, Patrick, for getting this little day in the life. We got a ton of questions. We'll try to get to them at the end. If not, we'll get up with people afterwards and answer the questions. So thank you so much. Now I want to pull up two people that are also on the front lines with employers. David Dow, Suzanne Jones. Suzanne is with NFP, Senior Vice President, Select and Mid-Market Accounts at NFP. And then David Dow, a Senior Employee Benefits Advisor at Hub. Both these individuals are on the front lines with employers. They understand employers and what's driving their behavior, and I'm looking forward to this session. Just kind of in the minds of employers and what you all are seeing. Do you have any opening comments before I start asking you questions, either one of you?
Sure, Doug.
I'll ask them. I mean, how do you deliver this concept of kind of, because you've all got clients that have at least started down a path. How do you get employers, because we all get it. The traditional is a giant easy button. I get it. The going with a carrier in a traditional sense, just press it and walk away. How do you get employers engaged in the conversation to at least consider alternatives?
Doug, I'm happy to start.
All right.
So thanks for having me. I'm super excited to be here, and I have to tell people I'm excited to be here because I'm so even-keeled it may not be apparent naturally. But Doug, we just have to tell them that something else is available. Once you say another way forward is available, so many employers are unbelievably frustrated with the current system that they're open to having a new conversation. We've done it dozens of times out there. It's absolutely the biggest trend in health plans for, smaller, medium-sized employers, which make up the bulk of your membership. So I think just making them aware that something else is out there. And when you point out the fact that every other part of their business has been analyzed, evaluated, and optimized, for many clients, many employers, their second biggest expense is benefits, and it actually hasn't been optimized. Looking at a spreadsheet every 12 months and making a reactive decision is not optimized.
Yeah, I agree. It's definitely a long-term discussion point, and I think both Dr. Bricker and Doug and Patrick mentioned that it's a collaboration between HR and the executive team of making sure that, HR teams typically want to have as much consistency. They want to make sure they're offering a competitive benefits package, again, for the current market where we're in for retention and attraction. But it is definitely a long-term conversation to say this is how you're going to be able to make changes. If the status quo, as you started and you kind of mentioned, you can kind of continue down that, look at everything every 12 months. But these are long-term conversations about what you really want to do with your employees and offering to them and trying to manage your costs and still offering a very competitive package.
So we all talk a lot, and so I know that the reality is that the majority of employers are still in a traditional world, right? And so what do you find of your clients that have kind of taken the leap? What are some characteristics? What about them sticks out? I mean, they're what's different about them? Is there anything different about them? And what do you think about that, David? What stands out from your clients that have made the move? What's different about them?
Doug, my answer to that question has changed over the last 5 years. 5 years ago, I would have said it was the top 1, 2, 3% of most progressively minded employers, most frustrated employers, risk-taking, adventurous, cutting edge. But you know what? Today, man, it could just be anyone. It could be any employer, 50 employees, 100 employees, 150 employees on the plan. It could be anyone. This is not a wild and crazy and out there decision for your plan. So we've seen actually the introduction to the implementation cycle shrink dramatically over the last 5 years. We just have your up and down the street manufacturer, wholesale distributor, blue collar, white collar. It could be anyone, Doug. It just takes someone who's open to a new idea.
Any thoughts here, Suzanne?
Yeah, no, I agree. I think it doesn't. There's not one size doesn't fit all necessarily. I think it's everybody trying to look at different challenges within their organization and what they are willing to kind of to look at and perceive. And again, healthcare is very personal. So when you start talking to the HR teams, they're very keen to try to find out how is this experience going to play out to my employees, and what is going to be, again, if they've been in a traditional, United Healthcare Blue Cross plan, how is this going to be different? How are they going to access care? What is even down to what is their ID card going to look like? Because that's how you feel like your health insurance is tangible. So I think those are kind of the conversations, but I think to David's point, it really kind of goes across all industries. This is not a white collar thing. This is not a blue collar thing. It just is up to what the strategy is, and that's what our jobs are, to help build that strategy out for each organization.
So let me dig on that just a little bit. I'll start with you, Suzanne. You'll get your turn in a minute, David. I'll dig on you a little bit. So back to my earlier question. So I hear what you're saying. It really could be anybody. The reality is, though, still most employers don't want to do this. What is it? What are the top 2 or 3 things that are really preventing the majority of employers from taking this step, from your experience?
Well, to your point, they're taking a leap, right? So most employers, and again, it's going to be size driven as well. So when you're talking about smaller employers, they don't have as many options. And what you do want to avoid is, so we'll talk about level funding, for a second, because that's also an option that we've seen people strategize. Most employers, again, are looking for consistency. So they're apprehensive to go into a different kind of financial strategy. And then maybe if it doesn't work out, then the next year they're having to, consider moving back into a different strategy. So it's really kind of, is this long-term, making it feel like this is a long-term move versus, okay, I'm going to try this out. I think that's probably what I would say might be an apprehension.
What do you think, David?
Oh, I think it's because the biggest challenge that we faced for the past several years is that convincing people that this is not as complicated and not as different as you may think, as they definitely think. So, at the end of the day, the employee experience is they get a card, it's going to have a network that's familiar to them. They're going to walk into familiar pharmacies, hand their card, get their drug, go home. They're going to be able to see doctors they're accustomed to seeing. For the most part, this experience doesn't have to be that much different. Back to Dr. Bricker's point, 5% of the people are the high utilizers. Not everyone's having knee replacement every year. Not everyone's having a rotator cuff surgery. Not everyone's having MRIs. And, when we make the point, when we point out the obvious to HR and leadership in a company, that the employees, the only employees in their company who are kind of healthcare experts or familiar with their plan are those who have been through large claims. And they became those experts after everything happened.
Right.
It's too late, right? I mean, our office, Suzanne's office, we all get calls helping people navigate stacks of invoices and EOBs. So what we're talking about is really putting resources and tools out there so that the 5%, 10% employees that are really driving utilization have the ability before claims happen to access Faith, to access a navigator, to access a pharmacist, and learn about their plan, their options before the claims happen. I mean, at the end of the day, that's really what we're talking about. Who does, when we explain it like that, who doesn't want that? What employer, what HR director doesn't want the employees to have that resource?
Yeah, and I think, there are more and more tools that are becoming available, obviously with some legislation regarding transparency. I think that's where these are the kind of things where somebody knows what's going to happen going into something versus finding out on the back end. So it's empowering employees, it's communicating so that they know how to utilize the platforms and that they're saving money, the health plan is saving money, and everybody's getting the right care as well and access to care.
Good. So I'm going to go back to our survey. This is my last question. I'll move on, I promise, about this topic. So we saw from the survey that the top one or two, really the top three concerns were around cost to the employer, cost to the employee, cost for drugs. Do you find when you look at the clients that make this move, is it mostly about cost for them, or is it mostly about the care the employees are getting, or something else? Like the drive, why they drive down this path? Is it financially related? I got a bad renewal, I'm ready to leap now, or is it more about the employee experience?
Well, I'll just quickly pop in and say I wrote down that only 12% said that they wanted data. They wanted to have transparency in data, and that is really, I think, one of the reasons why we see employers kind of looking at these arrangements, because they aren't getting data or data that is actionable. So I think that has become really important, that they can make decisions when they see that information. Now, they might not like what they see, but it does give them something, to digest versus, just kind of a number every 12 months.
Yeah, Doug, I'll answer your question. If I ask the HR professional, it's about the employee cost and experience. It's about, wanting better. I mean, they represent the employees in the organization. So if I talk to the CFO and leadership, it's about having that data, that transparency, that long-term plan, that insurance strategy versus a rental, having an insurance program versus a rented insurance plan that they have to renegotiate every 12 months. So, that's what drives the two audiences that we speak to.
Interesting. I asked this of Dr. Bricker. I mean, is this a all or nothing game? I mean, can some of these things, do you see it with clients where you might implement some of these things? Like, well, I want to keep, I'm not, to your point, says I'm not ready for a leap where we like the Blue Cross logo, our employees all like it, it kind of works. But this direct primary care concept's interesting. Do you see people kind of modularizing it, or is it pretty much a all or nothing kind of thing?
Patrick, I'd love to jump in. It's, listen, we see people walk, before they run all day. So the key is I think it was your very first bullet point on one of your first slides says you've got to self-fund. So that's it. You got to self-fund. You get on self-funded model with an appropriate, so people don't realize when you go self-funded, you still have insurance. So you're still buying insurance. But that insurance now, it's only about 30% of your cost for the average employer on this call. So you get the properly structured insurance to underpin your whole strategy here, and that limits volatility enough to make this appetizing to the small middle market employer, and that's what we're talking about. You put that in place, and then you decide how many other programs you want to layer in there. Sometimes it is a multi-year approach. I think probably Patrick, Dr. Bricker wants, they'd rather see people running right from the beginning. But, everyone doesn't have their confidence. These guys have been doing it for years. I've been doing it for years. I'm very comfortable running from day one. But I understand that a lot of employers, they need a little proof. They need to feel good and get their head wrapped around each step along the way. So that's a completely acceptable model.
Right. Yeah, I think, I think about, again, I say healthcare is so personal, to each and every employee. And so when I think about some pharmacy might be a concern for one employer, so they might want to use that as a module to try to incent, different things and try to manage specialty costs, which is very difficult. We all know that. When I think about traditional carriers and their, case management or disease management, again, a lot of the outreach, people are nervous to talk. They don't know what the motive is for someone reaching out to them, and so they're apprehensive. So in these models, when they know that this person is more of a personal relationship, like Faith is, then you just have to wait for that relationship to kind of, mature, but then you have a good experience, and then they share that with the next employee and then the next employee. So it kind of spreads by word of mouth as well. So I do think, to answer your question, I think some people would like to take the direct primary care piece of it and go with that, and some people would like to take the pharmacy piece and go with that. It just kind of depends on what their strategy is. But I haven't had anybody do one or the other yet.
Do you feel, I'm just curious, we're in a bubble today in this webinar, but if we kind of extract ourselves out of the bubble, and your firms work with thousands of clients around the area and nationwide, obviously, you both are part of big firms. What are y'all hearing from clients? I mean, are you feeling from the typical client a push this way, or are you having to pull them to it?
I think it just, again, not one size fits all. So I think we have some that are definitely hearing about, particularly, some of the smaller employers where there might be a level funded opportunity. They're hearing about that. It's more and more, I think, even in the media, we're hearing that that's a solution, because with the metallic plans becoming a lot more expensive. For the mid-size employers, they've always been anxious to, or some, not all, again, not one size fits all, but many want to self-fund before they're really ready to be partially self-funded. So I think that, we're definitely hearing it, we're introducing it, but then there is still a level of apprehension for people to take the leap, again, for various different reasons. But we know employee engagement is a very big part of it, and employee tools to help them understand the plans, and that's what we spend a lot of time talking about.
Yeah, Doug, I would tell you that the majority of employers out there just simply, they aren't asking, they don't know that another way forward exists. So, we are having to, to get on our stump and send the message and bring it to the market. If you take Blue Cross, for example, I bet they have 1,500 to 2,000 people like Suzanne and myself appointed to sell their group products in North Carolina. There's no way, there's absolutely no way 5%, more than 5% of those consultants out there are bringing truly innovative solutions to these middle market, underserved, employers. If you accept the fact, someone mentioned early on, every single large company in America is self-funded, that's indisputable. I mean, if you accept that as fact, they do it for one reason only, it's better. It's better. It gives them for a multitude of reasons why it's better. Control, cost, transparency, flexibility, actionable, actively managed plan versus a reactive plan, passively, managed plan. I mean, why aren't middle market employers self-funding? So they simply don't know about it. And our community, and I will tell you, I will speak for our community, we are not doing our part to bring it to stop doing what we've done for the last 30 years and bring new ideas to our clients.
Yeah, I agree. I think that's part of our role as consultants and brokers is to talk about innovative ideas. Again, it may not be the right fit for every client. And this is not, it's a long-term conversation. It's a conversation that has to happen before a renewal meeting, right? And then at the renewal, we can, digest a lot of these different opportunities. But I do think that we have to be aware of what's out there because they may know about some things, but they don't know about all of the options for sure.
Yeah, I've been accused of being a broker consultant. I'm not one, but I have a lot of discussions with people about this topic, and it's a dilemma. I mean, on the one hand, you feel the pain, you feel the concern. I got a bad renewal, or I had a bad employee experience, or whatever it is. But then it just feels like there, at least for the employer, it feels like a gulf between where they are and where they could be. And there's just a lot of things that can get in the way. And you guys are right in the middle of all that. There's just a lot of, I had one the other day where they were a perfect candidate. Well, we've got a few, 3 or 4 employees with bad conditions. So we can't do this. And that's not true, but we've been told we can't do this kind of thing. We hear that a lot. We can't do this. We can't do this. And just it's an interesting dilemma. Like you said, it's not as scary and as complex and as risky as a lot of people think it is.
It's our biggest challenge. And Doug, we put in our first, self-funded, high-performing, actively managed plan 7 years ago in North Carolina, and many more since then. And I'll just, maybe I'll come close to ending my section with this fact. I've never had a client go back. So that, to me, that speaks for itself. I've never had a client want to go back to the old model of fully insured, let's just get the spreadsheet every year. So, it must be working.
Can an employer, though, that likes the easy button, the spreadsheet, as you described, the spreadsheet exercise, I'm okay being on the merry-go-round and changing carriers every 3 to 4 years. I mean, can that employer, I'm assuming in these new plans, there's more work to be done by the employee. Can that person that likes press the button going back to life, can that person survive in one of these high-performing plans that requires more action and more analysis and more decisions? I mean, is it literally, do you have to almost change your mindset and be willing to invest more time, or can you just sit back like the easy button and live in one of these plans too?
Well, Doug, I think the market commonly accepts out there across the country that self-funding is 6 to 8, maybe even as much as 10% more efficient, but we'll go conservative, say 6 to 8% more efficient than fully insured plans over the long haul. So if you just made the move to self-funding, you had the right, the right stop loss model that again underpinned the plan. Pull fewer levers, get fewer, less return over the long haul, but still, in a 1 year period, I think this is important that, any of these self-funded plans can have more volatility, within a 1 year period. But that's what scares many people off. But when you look over a 3 year period, self-funded plans with the right stop loss model are actually significantly less volatile than the fully insured market that delivers 30, 50, 60, 70+% renewals when you have that bad year. So, we have to get people comfortable with that, understanding this is actually less volatile over a multi-year period, and we can show it and prove it.
Thanks. Parting thoughts, Suzanne?
No, I agree. I think it's, again, helping them develop that strategy, that it is a long-term, move. It is not something that you want to enter into and let's see if this works kind of attitude. That might be part of the mindset, but it certainly is something that you're moving to a different direction. And I think, to David's point, you can look statistically and see, maybe once every 5 years, the self-funded plan is going to have a bad year, or any plan could have a bad year. But you have to be prepared for that. And the average is that it is better. It's better. And the companies are keeping more of their own money.
Well, with that, I just appreciate all you both are doing, both to move more employers down this path, but also to just to help employ the majority of companies that don't want to. I mean, it's an important service. We all can get in these webinars and bash this or bash that, but I mean, heck, we only got our health, right? And you guys are at the center of that, helping employers to provide that service to employees. So thank you. I'm going to ask the panelists that are still here to pop back on, and we do have a few minutes here left for Q&A, and happy to try to answer some questions. As I always say in my peer groups, please ask questions, or I'm going to ask the questions that I care about, which may not be the questions that you care about. So I'm going to pull up my question. Any questions here, Julie? We can hop on here. One question was, I think it's you, David. If you've never had a client go back, how long have they been doing this setup, or this, I guess, this new approach? Is it?
Where our longest client, and again, we've had self-funded clients for decades, but the first, kind of 75-person company to go self-funded and really implement some of these programs, that was 7 years ago. So, I would say we've been doing it for 7 years here in the local market.
How do you get to print? How do you get to the level of, because again, this sounds, I know for a lot of employees, it sounds like, wait, I'm used to the spreadsheet exercise. I'm used to being told kind of what the thing is for next year. How does this differ as far as how premiums are set and how the plan design is set? That's the question we have now from an employer here.
I'll tell you, many of our clients who make the move into this model mirror the plan benefits they have now. So you can keep your drug copay tiers, you can keep your office copay tiers, you can keep your deductible. So, and actually I'm doing an employee meeting tomorrow morning for, a brand new client launching their plan, and their employees are going to hear the message that, by and large, the overall structure of their plan has not changed at all. What has been layered into it is, navigation tools, options to have benefits provided or services received at no cost. So they have options added. Nothing's been taken away from their current benefit structure.
Yeah, I think
have
that's
a question for Vinay that someone asked. Or Suzanne, did you have something to add?
No, that's fine.
Okay. So someone asked if you could give some specific examples on savings on specialty drugs. I'm sure that's a question you get a lot.
Absolutely, great question. Specialty drugs, as everyone has mentioned in the webinar today, is a rising, one of the fastest rising parts of a health plan cost, and it's not slowing down anytime soon. There's more specialty products being approved every year. So one of the unique programs we have access to is when a member we see all the claims that come through as MakerX, and we actually proactively review every single claim that comes out that we see every day. And so when we see a high cost specialty claim, the first thing that happens is a member will get a rejection of the pharmacy saying that there's a prior authorization required. So we go through and make sure that we communicate with the provider, the doctor, and make sure that that drug is appropriate. The member and the doctor have considered all the alternative options that may be lower cost or more cost effective. And if that drug, the specialty medication, is indeed truly clinically indicated, we'll walk the patient, hold their hand through, you'll forgive me, I say patient all the time, we're in healthcare, but your members will hold their hand, walk them through the process of filling out a patient assistance program application. And if they qualify financially, which all the criteria set by the drug companies, then they'll get access to $0 medication, and the plan will get a savings of up to 75, or actually at 75% of the cost of the medication. So savings of 75% on the specialty cost of the plan, no cost to the member. If for any reason the member doesn't want to participate or can't participate because of financial reasons, then we can allow them to continue to get the medication through the plan and access any specialty pharmacy that they want. We have access to cost plus specialty pharmacies, local ones here in North Carolina, or we can use any one that the plan or the member feels comfortable using.
Great, thank you.
And listen, I've got to add to that really quickly. I'm sorry talking so much, but listen, we're seeing the specialty patient assistance programs Vinay is talking about working 60 to 70% of the time, routinely, month in, month out. Our clients, we see the reports every single month, every single quarter. It is not a heavy lift, and Patrick, Vinay, back me up, to just simply take over a plan, implement a reasonable pharmacy like Mako and Vinay, and reduce pharmacy costs by 30 to 35%. I mean, just from day one. And these programs work. Can show you example after example after example of these patient assistance and copay assistance programs. They're available, been available for decades. The employees just don't know how to implement, integrate them into the plan.
Yeah, David, you're absolutely right. What's the first thing that we get excited about? And Suzanne and David can back me up on this. The first thing we see when we take over, when we look at a new plan, is specialty drugs, because it's where we can make the most impact quickly. And both the HR and the CFO would nod their heads in unison that that's a good thing, whether it's a Humira or an Enbrel or a Stelara or Skyrizi. As somebody said, those are the drugs that advertised during the Super Bowl. Those are, that costs tens of millions, $100 million. I think Humira is the first $20 billion drug. I mean, it paid for a lot of patent attorneys to protect it for decades long. But there is a way around it. It's just that your BUCA plan's not going to share that with you. You have to talk to someone like Suzanne. You have to talk to someone like David and say, I want a better way for but that employee that's hitting their out-of-pocket max and the plan that's getting damaged, the EBITDA, and you're just rewarding, you're complicit really in bad practices. And so it's the first thing we look at, specialty drugs. It's the quote unquote lowest hanging fruit. And then we're even pushing that down now to the tier below specialty, to the branded medications, where there's advocacy programs available for folks that spend $100 to $1,500 a month. They've kind of been left out by and large as this, movement to address PAPs or prescription assistance programs for the specialty meds is such a big deal. Billions of dollars flowing back to Wall Street out of your wallets every day, that now you take those same practices and apply them to the ones that have been quote unquote under the radar. But if you've got a $50,000 a year employee with a $2,000 a year drug, now they have help because we have advocates reaching out and doing PAPs for them. And so you got to stay nimble, right? Yep.
Thank you, Patrick.
We had a case like a similar Cali, again, just where the PAP wouldn't work, but Vinay's group was able to source the drug from Canada and save 25–30%. Now, again, I know healthcare is one of those topics where we all kind of wax and wane politics on it. And I had to remind, in this case, well, most of my medication comes from China. So I mean, it's not like all of our medicines come from North America. Some of them do, but a lot of them, probably more than we'd like to realize, come from other countries. So we've got 1 minute. Is there a quick question, Julie, we can answer?
There is. This is a really important question. And this is probably for our advisors. I'll have you guys answer this. I'm still not clear on how someone gets started down this path. Do I work with my current broker? Do all brokers do this? And also they asked, what is the time frame? Like if their renewal date's in January, do they get started right now?
Yeah, so I would say yes, you absolutely. So both David and I work closely with Patrick and with other companies that do similar things. And so now is definitely the time to start that conversation. So look at what the options are and to try to analyze the plan and see what we can do. And again, to David's point as well, it doesn't mean you have to change your plan design necessarily. It's just changing the mechanics behind it. So I would definitely say you can work with your current broker or work with David or myself, and we'll work with Patrick.
Yeah.
Suzanne, are you suggesting that you and David are available for new business? Is that true?
Oh, that is what we do. But the critical part is the timing. So many people say, well, hey, my renewal date's January 1st. Let's talk 60 days. Let's talk October 15th. You just can't start having a strategy conversation when you have deadlines driving you. You've got open enrollment, you've got benefit booklets, you've got websites to update. You've got to have that strategy conversation a minimum 4, 5, 6 months ahead of time. You don't wait until 30, 45 days before it's time to file your taxes to start interviewing CPAs. You just can't do that.
Yeah, everyone, I'm gonna call it there, but just like we learned that doctors are a bell curve, so are brokers, consultants. I mean, you've got two of the best here on the call today. If your broker is not at least exposing you to these concepts, it's a good question to ask why. And there may be a good reason, there may be a bad reason, who knows? But yeah, definitely raise the question to your broker if they try to talk you out of it. You know, it never hurts to get a second opinion, right? As we always say in healthcare. Again, thank you everyone today. Thank you also to Dr. Eric Bricker was here. Again, ahealthcarez.com. Thank you so much for Suzanne and David and Faith and Patrick and Vinay. Great job as always. Again, I hope everyone here took away at least one new nugget from here and that would be, I think, hey, there is a solution out there if you're willing to learn about it and take that first step. And it may not be as big a first step as you think it is. Again, we've got the perfunctory SHRM credits here, so I'm sure no one came to this session because of these. But if you'd like to get SHRM credits, here you go. Again, thanks again to all who participated. If we can help you, please call us. Here's some. I'm being forced now to do some promotions here. I'm sorry. You can tell I don't like doing it. But here's some promotions, some events we got coming up. We're going to be talking about culture here soon. We've got our next Hero Health webinar. If you're really intrigued by this, then come on July 14th and learn more about how Hero Health works, Hero Health is an example of a high-performing health plan. And then we've got our big conference, and we're so happy to once again be in person in Charlotte in September for an actual real live event. So I'm excited about that. Have a great day, everyone. Thanks again to our participants and to our panelists, and have a great day. Goodbye.